مرة ثانية تقديم محاضرته A Novel Approach to Middle Third Auricular Defect.
Cancer of the ear is common in the helical margin usually and in the post-auricular area. In this area, it's easy to remove and reconstruct with reasonable results. The antihelical and concal fossa, other parts, are more difficult to reconstruct and can be challenging. The usual way is to remove the cartilage and repair with skin graft, either split thickness or full thickness graft, but then you get change in contour and color. Other flaps are available, and that depends on the site of the tumor. I will best briefly say about the anatomy and the methods of reconstructions available. The auricle is a very intricate three-dimensional structure of very high aesthetic value. It's made of fibrocartilage at the upper two-thirds. The upper two-thirds are made of fibrocartilage, which is sandwiched by two types of skin: an anterior skin, which is thin, vascular, and adherent. The post-auricular skin is more pliable and less adherent, and is very vascular. We have various types of reconstruction. The aim of this is to restore the shape and size, and the choice depends on the site and the size of the tumor. As we know, we have this simple skin graft, which is split or full thickness, and that involves a donor site, and there is a change in color and contour. Other ways, we know that this wedge excision or star excision in tumors less than 1.5 centimeters, obviously this results in decrease in the height of the auricle. Other ways are this helical chondrocutaneous advancement flap, as described by Professor Amtier from India. Butler modified this technique by adding a cartilage graft and excising some of the scapula reduction. So again, this results in decrease in size and also a change in shape. Other methods using post-auricular flaps, using subcutaneous pedicle, but this has to be brought forward through a hole in the ear and involves obviously a donor site. Posteriorly also we can use this superiorly based myocutaneous flap, again, or inferiorly based flap, like so, but again pass through the auricle. What I have found, I have an 80-year-old lady who has an ulcerated BCC of her antihelical region. Here, we excited, it was not adherent to the cartilage, so we preserved the cartilage to also preserve the contour and size. And at that time, I noticed that she had quite a lax tissue around here. So I thought, why should I use other techniques if there is enough skin, so the end result was a 13 millimeter diameter defect there with exposed cartilage. So there we are. After the excision, I marked a rotational flap based on the excess skin that she had. As you can see, we just raised it and advanced it there and stitched it up. So it's a one stage and simple. This is the end result after 6 months. If you look at it critically, we can see here there is some notching there. I did offer the patient to get it in a better shape to remove that a little bit, but she was very happy with it, so we just left it. Here I just showed you a simple way of closing a defect in the middle third using a simple rotation flap, although it's not previously described. We looked at the literature, there is no record of this. It is an additional technique or method of repairing. It's very easy to perform. The main thing is we are using the skin of the same characteristics of the ear. The scar, the scar is largely hidden. It's not really not so. We avoid any donor site morbidity, and the aesthetic result is quite acceptable. And it is, I recommend this technique in certain selected patients to be used. Thank you very much.
Thank you, Dr. Jabir, and thanks to everyone who attend this symposium. It's a pleasure for us to have you all here, our mentors, our teachers, our friends, and residents, all of you here in Basra. I hope to see you next year in our biggest international symposium. My topic is age-reducing blepharoplasty. This is a new topic. Something has been developed during years of work in this field. It came from facing special cases in which the orbit is empty. All of you knows the changes that occur. Start the video. All of you knows the changes that occur during aging in the skin and the muscle, in the fat, and in the bone, in the orbit. I don't want to speak about that, but what I have seen that these changes is going to be corrected by blepharoplasty. But in special cases, we have only empty orbits. There is wrinkled skin, thin skin, redundant muscle, but the orbit is empty. There is nothing to be removed from it in order to rejuvenate it. And these was problem cases for me to start with. And I start to think how I can change these kinds of orbits and how I can get better results in these situations. That brings me to think about augmentation blepharoplasty and to add something to the orbit in order to improve its aesthetics. And that drew me to this new topic, which is age-reducing blepharoplasty, which evolved lastly. How I did that is by looking to my patients. I found that the age age-related changes in the orbit region is not limited to that region. That's obvious. The brow is going to be affected, the forehead is going to be affected, the the temple is going to be affected, the cheek is going to be affected, and all of that is going to affect our final results. So if we correct the deformity in the lids, in the upper and lower lids in classical blepharoplasty, we are getting a good image, but with a bad frame. So here I came with the frame concept. The frame is important. There is no image in the world presented without a perfect frame. If you don't put the frame to the picture, you cannot present it. So the frame is important. The structures surrounding the eyelids is important in order to get a very good results. And here I came with age-reducing blepharoplasty. When I started to correct all of these changes, which is occurring in the upper eyelid, in the lower eyelid, in the brows, in the forehead, in the temple, in the upper cheek, even the nasal bridge, it's going to be corrected in these surgeries. I started to get a picture of a patient which looks younger than before. And that was amazing for me. I was very happy, and my patient was highly satisfied, and that supported me. So I start the surgery. All the surgery is done under local anesthesia with the cover of a special regime of some sedatives and some non-steroidal anti-inflammatories in order to get mostly relaxed patients, sometimes sleeping and snoring, in order to do my job carefully. I do the classical work that all of us do it in blepharoplasty, which is resection of skin, some conservative resection of the muscle. I play with the fat cautiously, because the fat is the precious part here. I don't do full resection sometimes. I do judicious resection. It's a sculpturing technique. You should choose how much to remove in order to not leave it empty. Okay? And after that, I start to play with the framework, the frame of the picture, which is the brow, the forehead, the temporal part, the upper cheek, and even the lids itself. All of them, I apply fat grafting to them. Okay, the fat grafting is the magic tool in this procedure. Here in the videos, you are looking me doing the lower lid. After I finished the four, now the fat grafting started. It's in the brows. I use it here to augment the fullness, the beautiful fullness of the brows, and to make the upper eyelid, it flows in a harmonic way with the upper eyelid, and to give the nice curvature in this area. And that gives me also some elevation in the brow, and avoid the sagging and dropping down of the brow because of the skin resection. The temporal area is important also, very important. When we widen this area, the face becomes look younger, much younger. It's very, very important trick here. The temporal area is important, as you see. The upper brow is injected here. Also, with the brow, I inject some in the upper eyelid, but I don't pass the crease. In the cheek, also, fat grafting to the cheeks and to the lower eyelid in order to make it crispy, smooth junction between the lower eyelid and the cheek. There should be no indentations, there should be no breaking points, everything should pass smoothly in order to have a young-looking lower eyelid. All of this are done in the clinic-based facility, and it is under local anesthesia. My assistant do the harvesting and the preparation and the processing of the fat before I start the procedure. The time of the procedure takes sometimes 3 hours, 2.5 hours to 3 hours in total, from starting of harvesting to the end of the procedure. Here I'm giving the augmentation of the cheek also, which is very important to make it homogeneous. Here I'm augmenting also the nasal bridge, because this patient will have very subtle nasal bridge, and also that will affect the aesthetics. So here are some examples of how the age of the patient have changed. You can look, this patient may lost about 20 years of her age. How we can achieve this? By the frame concept. If we respect the frame and not pay attention only to the lids, we can get very fine. My patient is very satisfied, and myself, I'm very happy with these results. Because no one will blame you for these results. You can see here in the post-operative picture how the cheeks, how the crispy upper eyelid looks, and how it's shiny looking, youthful looking, even for the forehead, the temple. All of these structures should be corrected in order to get age-reducing blepharoplasty. The aim, nowadays, my aim and my speak to my patient is how many years I'm going to erase from the age of the patient, not how much aesthetics I'm going to give them. In this difficult case, thick skin, fatty patient, it's difficult to get good results. But with fat grafting, even in fatty patients, the result is amazing. This is the mother and the daughter, I call it. The mother and the daughter. The forehead, the brows, the upper eyelid, the lower eyelid. You can see the changes in the lower eyelid. It's passing smoothly without any indentation, without any irregularities. Thank you very much.